Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, and today I'm talking about dementia. I'm going to be using Alzheimer's as the exemplar disease to talk about dementia. There's one thing I've noticed as I've worked with a lot of people who are preparing to take NCLEX or who have already taken NCLEX is people who do not know the difference between dementia and delirium often don't pass NCLEX. It's a fundamental difference between dementia and delirium that if they don't know the difference between those two things, they often don't know other key information. So that's why I'm talking about this today. I also noticed I hadn't done much neuro, so I want to do more neuro, and stay tuned. We're coming right up. Hello, Clinic Review family. It's Dr. Sharon. Today I am taking a break from the blue book, and we're going to be doing Alzheimer's. I don't know if you've noticed, but right here I have Florence Nightingale peeping over my shoulder. Y'all have to tell me, should I leave Florence Nightingale peeping over my shoulder, or is she creepy and spooky looking? So I had a former boss who I really admired a lot. She gave me this as a gift for Nurses Day or Nurses Week, whatever it is. And I had it on a shelf for a long time, and then I kind of put it away after I moved out of the office I was in. And I recently found it. I was cleaning out my storage and I found it and I thought, oh, I'll put it in here. But now I realize she's creepily peering over my shoulder. So tell me in the comments if you think I should keep Florence Nightingale looking over my shoulder or if I should take her down. All right. So you know that I'm a part of the bigger Clinic Review organization. You can sign up for our streaming service at clinicreviews.com. You can sign up for our online small group tutoring, or you can sign up for the Clinic Review on demand. So let's go ahead. Since I'm not doing the blue book, I'm going to be doing some teaching today. So I don't always do a lot of teaching. I mean, I do a little teaching as I go through questions, but I'm going to start out with teaching today. And so I'm talking about dementia, and there are two kind of common reasons people experience dementia. Okay. Alzheimer's disease or vascular dementia. Alzheimer's disease, there's a lot of words here. I kind of highlighted in red the things that I really want you to know. So what causes Alzheimer's disease? They don't really know, to be honest. Could be a virus, which is what they say about type 1 diabetes as well. They have no idea what causes type 1 diabetes either. So maybe it's viral. But it's really more genetic than anything else. If someone in your family, mom, grandma, aunt, uncle has Alzheimer's, you're more prone to get it. Whereas vascular dementia is a result of having a stroke or multiple strokes, and actually has some vascular degeneration. Pathophysiology of Alzheimer's disease, again, they don't know what causes it. So all you got to remember is that it's chronic. Y'all, dementia is chronic. It doesn't get better. I don't care if it's vascular dementia, Alzheimer's dementia. I don't care what kind of dementia it is. It could be alcoholic dementia. Wernicke-Korsakoff is alcoholic dementia. When you hear the word dementia, you should think chronic. It doesn't get better. And usually it gets worse. Alzheimer's is the one that you can pretty much guarantee it's going to get worse. Okay, Alzheimer's is chronic, degenerative. It will get worse. Vascular dementia gets worse if they have more strokes or they have more vascular problems. Alcoholic dementia gets worse if they keep drinking. So there are some precursors for the alcoholic dementia and the vascular dementia, but Alzheimer's is guaranteed to get worse. Vascular dementia is caused by impaired blood flow. The course of the dementia in Alzheimer's is steady and gradual. That it does, in fact, get worse, and it's both cognitive and mobility. So steady and gradual decline of cognitive and mobility. And ADL function will gradually decline from mild through the more severe stages. So they're not able to take care of themselves anymore. They usually die from the complications of immobility. They fall or they stop eating or something like that, and then they can't feed themselves, they forget to eat. And if someone's not force feeding them, if they don't have someone who makes that decision, they get a feeding tube or something like that, they will die from the complications of immobility. Vascular dementia, because it is a vascular problem, they often die from another big stroke, a heart attack, or another vascular issue. Risk factors for Alzheimer's and vascular dementia: Alzheimer's more common in women, vascular dementia more common in men. Both the risks go up as they age. Traumatic brain injury also can be a precursor to Alzheimer's. And then the risk factors for vascular dementia are any of the vascular issues, atherosclerosis. So if they have hypertension, myocardial infarction, diabetes, all the things that are risk factors for atherosclerosis and vascular disorders, obesity, smoking, those all put them at risk for vascular dementia. And then the management of Alzheimer's disease, I should have put this in red, cholinesterase inhibitors. Okay, so safety measures to prevent injury, to prevent wandering, to prevent falls. Those are safety things that you don't want them wandering off, getting lost. They don't know where they are. Sometimes people can hide their confusion for a long time. They may be able to talk because they know they're confused, and they may be able to talk sort of about everyday events, like how you doing? Did you see the game? And they can kind of hide that oh yeah, I saw that. That was a great game. And they kind of let other people give them cues about what they're talking about. They can also talk about distant past events. They tend to forget current events. They can talk about distant past events. So sometimes you didn't even know Dad was confused until he was driving and he got lost going to church that he'd been to 100 times. And then all of a sudden he got lost, or he forgot where he was going after he got in the car, and that kind of thing. So there's behavior management, ADL assistance, safety assistance, and then cholinesterase inhibitors. And I'm going to talk about those more on the next slide. And then vascular dementia, we know it's not a cholinesterase issue. Cholinesterase is what breaks down acetylcholine, and they think it's a lack of acetylcholine that predisposes a person to Alzheimer's. So cholinesterase breaks down acetylcholine. So if we can inhibit cholinesterase, we can prevent the breakdown of acetylcholine. It doesn't cure the disease. It just treats the symptoms. So even when they're on a cholinesterase inhibitor, they still will continue to decline, but it can help with some of their memory problems in the short term. And then vascular dementia, modify your risk factors, behavior management, stop smoking, lose weight, that kind of thing. Manage your high cholesterol, manage your hypertension, and so forth. So we're going to focus on Alzheimer's dementia because it's sort of unique in that there's no way to stop its progression. Vascular dementia, you can possibly slow its progression. Alcoholic dementia, you can stop drinking, you can slow its progression. Alzheimer's dementia, you can't slow its progression. And I just want to make the point that dementia is chronic and irreversible. You can slow it with alcoholic dementia and vascular dementia. You can slow it or even halt it, but it's never going to get better. So the hallmark of dementia is that it's irreversible. Once you've suffered whatever has happened that's caused the dementia, you're never going to go back to normal, right? Delirium is acute. Okay, delirium is acute, and you can have acute on chronic. So if someone comes into the hospital, they have a history of Alzheimer's dementia or vascular dementia, doesn't matter. They have a history of dementia, and they come in, and they've been functioning fairly well at home, and all of a sudden in the middle of the night, they start screaming and crying. They rip out their IV. They throw their telemetry off, whatever it is. You've probably seen all this stuff. And you go, oh man, their dementia's getting worse. Y'all, their dementia is not getting worse. It's a delirium on top of a dementia. Okay, dementia is chronic progressive. If you have an acute confusion in a dementia patient, it's not the dementia getting worse. It's delirium on top of the dementia. Delirium is acute, and it's a chemical imbalance often associated with illness. So this is delirium is what happens when older adults get a UTI or pneumonia, and they bring them into the hospital because they're so confused and they can't figure out why grandma's confused because she was fine. And we find out she has pneumonia, or we find out grandpa has a UTI, and they're delirious, and they get better, after we solve the problem or fix the disease or the infection or whatever. So a person with Alzheimer's dementia can have an acute delirium on top of the dementia. And that's a key thing to understand. If you don't understand the difference between dementia and delirium, then there's probably a lot of holes in your knowledge. And I don't want to overstate that. I'm not saying you don't know anything. You probably do know a lot of stuff, but maybe watch more of the fundamentals videos that I've done. Make sure you don't have a lot of holes in your knowledge. Do a lot of those walk through the blue book videos that I've done. Get the blue book. The blue book has a lot of fundamental knowledge in it. All right, let's go ahead and keep going. So let's talk about these cholinesterase inhibitors. So the thought with Alzheimer's is that it's a lack of acetylcholine. So we want to block cholinesterase so that we're not breaking down acetylcholine. So cholinesterase inhibitors block the break or prevent the breakdown of acetylcholine. So Aricept is one of those examples. It's pretty universally given. You can really give it any time during the process. It prevents the breakdown of acetylcholine like all the other cholinesterase inhibitors, and it improves symptoms. So that's the typical explanation of what a cholinesterase inhibitor is. Prevents the breakdown of acetylcholine, and it improves symptoms. And there's Exelon, which is rivastigmine, prevents neurotransmitter breakdown, used in memory, which is acetylcholine, and it's used in mild to moderate dementia. So they may have them on Exelon early on, but then they can change them to the memantine or the donepezil memantine combination to prevent to be used in moderate to severe dementia. So memantine and donepezil can be used concurrently. Memantine we start later on with more of the severe symptoms. I didn't look up all the pharmacology of that, why one works better than another, depending on the stage of the disease. I don't know why that is. And honestly, you don't need to know why that is either, unless you decide to become a pharmacist. And then the extended release, galantamine slows breakdown of acetylcholine, used in mild to moderate dementia. So they're not going to ask you to choose between these medications. You need to know why cholinesterase inhibitors are used. And that's really all you need to know. And I would know these names: donepezil, rivastigmine. I don't know if I said that right. And then memantine, galantamine. So we've got a lot of ines at the end. And then the donepezil, I don't know why it's got a different name. Aricept, it seems like everybody, I don't want to say everybody knows it, but that's the one I'm most familiar with, is the Aricept, donepezil. If I see that, I know it's an Alzheimer's med. And then two of the symptoms, and these are really for the purpose of vocabulary words. Agnosia is associated with dementia. Okay, any type of dementia, a group of conditions where your brain can't recognize something even though your senses can detect it. So they see a pencil, and they know it's there. They see it, but they can't remember what it is. They're more likely early on to forget where they are before they can't recognize familiar objects. Failure to recognize familiar objects doesn't start to occur more into the moderate to severe stages of Alzheimer's. Early symptoms, I can't remember where I am. I don't remember what time it is. I don't remember what day it is. Where am I? Why am I here? But I do recognize these are my car keys. I do recognize that I'm driving my car, but I can't remember where I'm going or why I got in the car to begin with. So when you think about mild to severe, think of, I don't remember why I came here. Then it goes to, I don't recognize familiar objects. And then I don't recognize familiar people. So that's kind of where we go. And then they start to lose mobility. And then psychosis. Psychosis is impaired senses and impaired thinking. So this is what you see with really any type of psychotic illness. You see psychosis in schizophrenia. You see it in bipolar. You can see it in severe depression. But psychosis is also a part of dementia. Any type of dementia can experience psychosis. So delusions are a false fixed belief about something that's not true. So I know when my grandma developed dementia late in her life, she always adored my dad. Like she was my mom's mom. So my maternal grandmother loved my dad. And later in life, she became very suspicious of him. She thought he was trying to steal from her. Well, he wasn't trying to steal from her, obviously, but she became convinced that he was. That's a delusion. And then they also have hallucinations. And I know that Alzheimer's patients or demented patients can have hallucinations because we've all taken care of people who've had them, right? So they're in their room in the middle of the night saying, "Call my husband, call my daughter. Why is there a mouse under my bed?" And you're like, "There's no mouse under your bed. Your husband's been dead for 10 years. Your daughter, you don't have a daughter," whatever. They hear things that aren't there. They see things that aren't there. They feel things that aren't there. And so hallucinations are those things. And then impaired thinking, impaired senses. So those are also symptoms associated with Alzheimer's. Let's get into some questions. I know that was a short lecture, so to speak, and you probably in your nursing classes had a much longer lecture on Alzheimer's. Although certainly lecturing longer on Alzheimer's, you might find interesting. I try to focus on the things you need to pass tests. Okay. So I'm not your professor. So don't think that your professor shouldn't teach as much as they do. I am a college professor, by the way. I start school next week again for the fall. And if I were teaching Alzheimer's in school, in class, my lecture would be much longer. So don't think that your professor shouldn't be teaching as long as they are. I'm just focusing on key things that I think you need to know to pass a test. I'm not focusing on everything you need to know to be a nurse. Okay. All right. A client is being discharged to home with progressing stage 1 Alzheimer's disease. So I go, well, probably mild. I may not know all the stages right off the top of my head, but I figure, well, it's sort of mild. So they're probably not always sure where they are, what time it is, and why they got in the car and why they're holding the television remote. What was I doing with this? The family expresses concern to the nurse about caring for their parent. What is the priority for best continuity of care? And remember, you want to answer the question that's being asked. So they're early stages of Alzheimer's, but the family is concerned about caring for them, and we need to say what's best for continuity of care. So let's relate each answer back to the question so we don't get confused about what we're answering. Assigning a case manager would be best for maintaining continuity of care. Well, that seems like a good idea. What is a case manager? A case manager is somebody who knows everybody who's on the team, make sure people get to where they need to go and that they have all the people assigned. Well, that's a good way to assure continuity of care. Isn't that what case managers do? Isn't that their job, to assure continuity of care? Ensuring that all family questions are answered before discharge is best to ensure continuity of care. Well, answering other questions before discharge is good, but doesn't facilitate continuity of care. That's not what it does. Providing a safe environment is best to ensure continuity of care. Well, no, providing a safe environment is important, but it does ensure continuity of care. Referring the family to an Alzheimer's association is best in ensuring continuity of care. Well, no, referring to a family to the Alzheimer's Association is great. It provides good information. It could be a support for them, but it doesn't ensure continuity of care. So I want to stress to you that you need to make sure you answer the question that is being asked. If you're not sure, like if you get it down between two answers, and you're like, I don't know which one it's supposed to be, relate each one back to the question and say which one better answers the question that I'm being asked. You have to answer the question that is being asked. You're not just looking for a good answer. You're looking for the right answer for the question that's being asked. I've said it too many times. I'll keep moving on. A client with early stage Alzheimer's disease is admitted to the surgical unit for a biopsy. Which complications should the nurse watch for? Skin breakdown due to impaired mobility, worsening dementia from the new environment, delirium during the hospitalization, urinary incontinence due to confusion. All right, I'm going to cross off A because there's no reason to think they have impaired mobility. They're early stages of Alzheimer's. Worsening dementia. So dementia is chronic. It doesn't worsen from a new environment. So that's just an inaccurate statement. B is delirium during the hospitalization. Well, someone who has underlying confusion and is sick could definitely develop an acute delirium while they're in the hospital. That's actually a very common complication of chronic confusion is acute delirium. So I am concerned about C, urinary incontinence due to confusion. There's no evidence they're confused, not confused to the point of urinary incontinence. I mean, they probably have some forgetfulness. They don't always know where they are. And that's why being in a new environment can cause an acute delirium because they don't already struggle to know where they are. And then they're in a new environment and they're like, why am I here? What's going on? And they get very confused. So really the only answer that even makes any sense here is C. C is the only answer that makes sense. The spouse of the client with Alzheimer's disease is listening to the home health nurse explain the client's drug regimen. Which statement by the spouse indicates an understanding of the nurse's instruction? All right. So, which one is a true statement? Okay. They indicate the understanding. Donepezil, Aricept will treat the symptoms of Alzheimer's disease. That is a true statement. Memantine is indicated for treatment of early symptoms of Alzheimer's disease. So I did teach you that memantine is used for moderate to severe, but let's say you didn't know that. Okay, let's just say you didn't know if it was. So let's say we'll put a question mark next to it, like we don't remember if that's true or not. We know it's false, but we'll pretend we don't know that. Rivastigmine is used to treat depression. Well, I know that's a Alzheimer's drug. It's a cholinesterase inhibitor, so I know it's not used to treat depression. Sertraline, which is an antidepressant, will treat the symptoms of Alzheimer's. I know C and D are false. So I might be, if I don't remember memantine and when it's used, I might be unsure. But I know for sure that donepezil will treat the symptoms of Alzheimer's disease. I know that for sure. Even if I can't remember if memantine is used early or late, I know A is true. So what I want to make sure you understand is pick the answer you know for sure is true, not the one you're unsure about. Don't go, well, maybe they're trying to trick me. They're not trying to trick you. They're trying to see if you have enough common sense to pick the answer that you know is right. The nurse is caring for a client with advanced Alzheimer's. Which communication technique is best to use with the client? All right, this is a best question, which means there may be more than one answer I like, and I have to figure out which is best. So advanced Alzheimer's communication. Providing the client with several options to choose from is best when communicating with an advanced Alzheimer's disease patient. Well, I know that's false. I don't even have to think about that one because they have trouble making decisions. We're not going to give them multiple options in advanced Alzheimer's. That's not good. Assuming the client is not totally confused is best when communicating with a patient with advanced Alzheimer's. Maybe. I mean, they may remember some stuff. I mean, they probably remember distant past stuff, and maybe they remember some things, even if it's advanced. I mean, they're not totally confused about everything, right? So maybe, B, maybe. When dealing with a client with advanced Alzheimer's, it is best to wait for them to express a need. That doesn't seem like a good answer to me because they might forget what they need. They may not remember how to express it. They may forget what things are. I don't like waiting for them to express a need when they're severe or advanced Alzheimer's. I don't like C. When communicating with a patient with advanced Alzheimer's, it is best to write down instructions for the client. Okay. I like D. I do have to remember that in advanced Alzheimer's, they don't always recognize things. So will they be able to recognize words that are written on a page? I don't know. So let's do our best technique when we get it down to two. When you get it down to two, you say, I'm going to do one, but not do the other and see which one looks better. I'm going to assume the client is not totally confused, but I'm not going to write instructions down. Okay. I'm going to assume they're not totally confused, but I'm not going to write instructions down for an advanced Alzheimer's client. Or I'm going to write stuff down for them, but I'm going to assume that they are totally confused. Well, that doesn't make sense. If I'm assuming they're totally confused, why would I write things down for them? If I think they're totally confused, writing them down wouldn't help. So choosing D doesn't really make any sense for an advanced Alzheimer's disease client. It seems like out of all these answers, it seems like the best answer is assuming they're not totally confused. And if you don't understand totally confused, totally is an extreme word. It's an extreme word. It means it's like always or never. You could change totally to always, assuming the client is always confused. Well, I don't want to assume the client is always confused. That's just not good. And so assuming the client is not always confused or not totally confused is a good communication technique. We're going to be able to communicate about some stuff. So I like be best. Now remember, the right answer is the right answer because of the other answers. Out of all these answers, B is the best one. I'm not saying that this would be the best answer if there's other better answers, but out of these, this is the best one. The nurse is educating a group of older adults about risk factors for Alzheimer's. Which of the following individuals is at highest risk for developing Alzheimer's? A 65-year-old male with a history of hypertension and diabetes. Well, that person's at risk for vascular dementia, not Alzheimer's disease. A 50-year-old female with a family history of breast cancer. Well, she doesn't have any family history of Alzheimer's, or they would tell me that. Breast cancer is not a risk factor, and she's not over 65. So I'm not thinking the B is the highest one. 45-year-old male who exercises regularly and has no chronic illnesses. Nothing there that tells me they're at risk for anything. 70-year-old female with a family history of Alzheimer's and a history of head trauma. All very big risk factors. The age, the Alzheimer, family history of Alzheimer's, and history of head trauma. All very big primary risk factors for Alzheimer's. A patient with Alzheimer's disease is becoming increasingly agitated and is attempting to remove their clothing in the middle of the day. Which action should the nurse take first? All right, it's a first question. So there may be more than one thing that I'll do, but I have to know which one is first. Restrain the patient to prevent them from undressing. No, that's not a good answer. Not a good answer at all. Redirect the patient to a quiet activity in a calm manner. So redirection is one of the best things that you can do for a patient with dementia. The psychosis of dementia, we teach in the clinic review. We teach about the psychosis of dementia, Alzheimer's being one of them. We don't specifically teach about Alzheimer's, but we talk about the psychosis of dementia. And we talk about how redirection is the best thing. So if you've taken the clinic review, you should be able to recognize that B is a good answer. Administer a prescribed sedative. Absolutely not. That's the same as restraining them. No. Ask the patient why they're undressing. Y'all don't ask why. Don't ask why questions to confuse patients. Okay, that's not a good option. Redirection, and you might say, "I've tried that; it doesn't work." Y'all, NCLEX is a perfect world. On the NCLEX, redirection is going to work. I know. Look, I know it doesn't always work. When the patient's confused, they can get agitated. They can say, "No, you're trying to kill me," about all this, right? There's other things, but this is first. What are we going to do first? That's the question. Okay. Maybe eventually we'll have to be more aggressive in our intervention. But first, we're going to try redirection. Absolutely. A nurse is preparing a patient for diagnostic tests to confirm a suspected diagnosis of Alzheimer's. Which test is most commonly used to assess cognitive function in Alzheimer's patients? Y'all, there's no good test for Alzheimer's. There's no good diagnostic test for Alzheimer's, like physical, like MRI, CT, any of that. Those are not good tests for Alzheimer's. You can see vascular dementia, but it's not great for Alzheimer's. MRI, no. EEG, no. Mini mental, yep. That'll tell you, assess cognitive function for sure. Lumbar puncture, nope. C is the only one there. MRIs, EEGs, lumbar punctures, CT scans, they're not great for diagnosing Alzheimer's, and they don't assess cognitive function at all. Only the mini mental assesses cognitive function. If you don't know what the mini mental is, just Google it. It's all over. You can learn about it. It's a series of questions you ask somebody to remember how they're doing. Cognitive function. A patient with Alzheimer's disease is prescribed donepezil. Which statement by the patient indicates an understanding of the medication's purpose? I don't know how good this question is. I don't know if my patient would remember why they're taking it if we're prescribing it, but they might. They just might not remember it for very long. This medication will cure my Alzheimer's. No, it doesn't do that. There's no cure for Alzheimer's. This medication will prevent me from developing any complications. No, that's not true. This medication will eliminate my memory problems. No, that's not true. This medication will help slow the progression of my symptoms. That is true. It will help slow the progression. I'm not sure if they would. I'm not sure how well we could teach them that. I mean, maybe in the short term they could remember it. A nurse is caring for a patient with advanced Alzheimer's. Which complication is the nurse most concerned about? Depression, falls and injury, weight gain, or hypertension? So if you remember back to the chart I had originally, it said on there, and I told you that injury from mobility, death from injury related to mobility issues is one of the more common reasons people die who have Alzheimer's. So falls and injury is our biggest concern. with advanced Alzheimer's. The nurse is educating the caregiver of a patient with Alzheimer's disease. Which construction should the nurse include to help the caregiver manage the patient's wandering behavior? Okay, wandering behavior. And wandering behavior is a big deal with any type of dementia, alcoholic dementia, vascular dementia, Alzheimer's dementia. Wandering is a big issue. They forget where they are. They forget where they're going. They forget why they're going, where they're going. Install locks on the doors above or below eye level. So I don't know if you've processed this before, but locking doors is a good way to prevent wandering. That's why dementia units have locks on the doors to prevent wandering. And so actually installing locks above or below eye level. So if they walk up to the door and they see the lock, they're more likely to turn the lock. But if they don't see it as they walk up, if they start looking around, they may forget by that time what they're doing. And why they're even at the door. So that does work. Encourage the patient to take long walks outside alone. So the idea maybe is that we can get them tired out and they won't wander. But if we let them walk outside alone, y'all, no, that's not going to work out. They're going to forget where they're going. Using physical restraints, absolutely not. Absolutely not. That is considered unethical. Limit the patient's fluid intake in the evening. Well, no, we're not going to dehydrate them. Good grief. So installing locks is considered sort of the standard of care for preventing wandering with patients who have dementia. And that would be true for any type of dementia. The nurse receives a report on 4 patients with Alzheimer's disease. Which patient should the nurse assess first? Okay, who do we assess first? We assess patients who are unstable. What makes a patient unstable? Unexpected symptoms is one of the things that makes them unstable. A patient who's asking to call her husband who's been dead for 8 years. Well, that's expected. I mean, that behavior is expected for a patient with Alzheimer's disease. A patient who's alert but only oriented ×1. Well, that's expected for a patient with Alzheimer's. A patient who's not eaten for 12 hours and is refusing meals. Well, that's a problem. That's unexpected, actually. Refusing to eat may be a complication, but it's not necessarily expected. That could be, but I mean, that is a complication, and we don't want them to be injured because of dehydration, right? So we need to go see them. What's going on? A patient who is scheduled for a CT scan in 30 minutes. No, that doesn't make them unstable. There's nothing about that makes them unstable. So I have to see the patient who's refusing to eat. A nurse is communicating with a patient in the moderate stage of Alzheimer's disease. Which communication strategy is most effective? Moderate, most effective. Speaking quickly to provide as much information as possible. Well, that's not ever a good, that's not a good NCLEX answer. I don't care what the problem is. A is a bad answer. Using complex sentences to stimulate the patient's cognition. Again, never a good NCLEX answer. We're not doing that. We're taught as nurses to provide education at like a, I don't know, 4th grade like all the stuff they read. It's supposed to be at a 4th grade reading level to make sure everybody understands it. You'd be surprised the difficult words that are in a 4th grade reading level. So no, we're not going to use complex sentences to anybody. Providing written instructions for tasks, that's okay. That's good. Using simple direct statements and repeating as necessary. That's good as well. All right, so I've got 2 answers that I like. So we're going to use our best strategy. I would provide written instructions, but not use simple direct statements and repeat as necessary. Well, that's not good. I'm going to use simple direct statements and repeat as necessary, but not provide written instructions. I mean, I have to do D. I have to. I can't give them written instructions and then use complex indirect statements. Like, I can't do that. I have to do D. And you might go, don't you have to provide written instructions? Honestly, no, I don't have to. I mean, I can, but I don't have to. If I have to do something, I have to use simple direct statements and repeat as necessary. I have to do that. All right. Well, that's the end of that. I hope it was helpful to you. If you're like, well, Sharon, some of that stuff didn't help me all that much, just think about it, like process it. And you can send me messages. I read your messages that you put, comments you put on my videos. I really do. And some of them I don't respond to because like maybe they're just comments or whatever, and there's not much I can say to them. But I do get the comments where like, I don't agree with this. I don't agree with that. That's fine, y'all. This is my opinion in teaching you how to pass NCLEX. But if you don't agree with me, just think about it for a minute, like maybe more than a minute, like process it, right? Like chew on it. Okay, like a cow chewing on their cud, like, I'm going to chew on that a little longer, right? Like, chew on these things. Think about them and think about why I'm telling you these things, because I'm teaching you how to pass a test. I'm not teaching you how to be a nurse, teaching you how to pass a test. Okay, so just remember that as you're answering questions and as you're thinking about what I'm teaching you. So I hope this was helpful. Remember to tell me in the comment if you think I should let Florence keep looking over my shoulder. Thank you for watching to the end. Thank you for being a subscriber and for being a member. We'll see you later. Bye.